Okay, so we're going to start with monitoring. And again, we've done chapters 1 and 2, and now we're going all the way to 6. But I'm moving around because I want to go over um, the basic monitoring parameters, which, when I talk about patient reactions to anesthesia later, when I talk about drugs, then you already kind of know what I'm talking about when I talk about these side effects. But this is the kind of know your patient portion of my whole know your patient, know your drugs, pay attention. This is the pay attention part, to really try to keep them safe. One thing to think about broadly and start to put this in your brain is you think about how does a patient act when they're completely awake, 100% awake, and when they're 100% dead. I know that sounds strange, but what we're looking at is what are vital signs doing as we transition a patient from completely awake to we don't want to get to this point. What do we expect a patient to do with their reflexes, with their blink, with their swallow? Will an animal awake let you completely open their mouth? They probably have some jaw tone. On the flip side, if an animal was deceased, their jaw is completely, there's no muscle tone. So what's going to happen to a patient, for example, with jaw tone is, now remember, in the beginning of anesthesia, we talk about sedation or tranquilization. Now that's a patient that is conscious. Now they may look out of it, but they could literally still respond to their name. They could potentially wag a tail. Even a dog that's well sedated has a little bit of jaw tone. Now, when we travel through that hypnosis narcosis band, now this is that was in the last PowerPoint where it talked about awake and it talked about traveling through the stages of consciousness, basically. Now, as we travel into what we call induction of anesthesia, induction is when we put them in a state of unconsciousness. So we sedate them first to calm them. And then if we give the propofol, which is an induction agent, they lose their swallow reflex. We can intubate. Then they are unconscious because we're probably going to do surgery. And then how do I expect the reflexes to work or the vital signs to work in an animal that's anesthetized? Obviously, things are going to start potentially heart rate, respiration, jaw tone, blinking, swallowing, reflex. Like if I pinch their toe and I want them anesthetized, they shouldn't be able to react to a pinch. So a lot of times under the table, I'm like pinching their toe and I'm seeing, are they feeling that? Because if Dr. Ritz is ready to do a spay and open the abdomen, if they can feel this, they're going to feel that. So just keep that in the back of your mind. And we're going to talk about the different ways that we monitor. You're fine, Katie, I get it. We're going to talk about the different ways we monitor through these parameters. So everything that we're looking at is like, what do we assess? The first thing is we have to look at vital signs. What are the vital signs of a patient? And this is basically the body's homeostatic mechanisms in response to anesthesia. Now remember, the body always wants to keep things in balance. The problem is we are giving drugs that are potentially altering these functions. So the body is reacting to the drugs we give, and we are trying to maintain a good balance. Obviously heart rate is important and the rhythm of the heart is important. So are those staying the same? Respiratory rate and depth. And again, I'm a stickler on respiration because the way an animal breathes under anesthesia, there is definitely when they're close to death, respiration changes, the character changes, the way they start to breathe. And you guys will develop this, but I have a lot of gut feelings. Sometimes my brain just goes, something ain't right. I don't like the way they're using their abdomen to breathe. I don't like the pattern of the ECG, and things like that. So what you need to do, obviously when we do a physical exam, what is normal for that patient? If my patient starts out with respiratory distress, I might see it. But if I had a normal animal breathing completely normal at the start, and now I'm having issues, that's a new issue, if you see what I'm saying. So you got to know what you're starting with. And hopefully you're starting with a nice, healthy patient, but you know, not every animal is going to fit into this little cookie cutter, you know, mold. I don't know if you guys were at the school. We got a bunch of those little poodle things from a rescue. There was a bunch of there was 3 or 4 of them. And, you know, those dogs had dentals and they were not exactly, you know, the crowning anesthesia patient. They had some issues under anesthesia. They were not necessarily healthy when they came from the rescue. So, you know, you guys mostly in surgery rotation are going to encounter basic spay neuter healthy patient, but then we're going to have the ones kind of that fall out of that category. The difference between heart rate and rhythm. So a heart rate is just how many beats per minute, okay? And we're going to go over what is normal for a patient's heart rate during anesthesia. Like, when do I worry? Now, rhythm, is it on a regular, you know, when you listen to a heart rate, it should be like listening to a song. You know, you're just like singing loud, and then your record skips and it goes, duh, and you're like, you know, you were kind of in like dude, this is a good song. And then all of a sudden something, you know, so when I listen to the heart rate, I should literally kind of be lulled into a beat. So there is the rhythm. Is it happening regularly? And then is that rate normal for that patient? And for example, cats are typically well above 120 beats a minute during anesthesia. Now, in awake cats, like 180 to 220 beats a minute. But if I have a cat that has a heart rate below 100, and I had a cat that was below 80, it was getting an MRI, and it didn't have a bradycardic agent. It didn't have a drug that made the heart rate. And, you know, I called down to the doctor and I was like, look, you know, this cat's heart rate is pretty low. It ended up, it had a very low temperature. So part of hypothermia can cause bradycardia, but then we treated the heart rate with a drug called atropine, and that brought up the heart rate to a, you know, acceptable level. So kind of what I'm going to talk about is our heart rate normal? If it's not normal, what are the reasons it's potentially not normal? So there's going to be checklists that are going to be very important. My cat didn't get a drug that makes its heart rate go slow. It didn't have a slow heart rate when I anesthetized it, but it was cold. And so then I'm like, okay, it's probably hypothermia. So how am I going to treat that? I'm going to try to warm up the cat if I can. That takes a little bit, okay? So it's once they get cold, it takes quite a while to warm them back up. So we always try to prevent them from getting cold. But if you can't do it, then the next thing is to give a drug that will increase the heart rate in the meantime. And that's why we use that. So if you listen to my thought process, this cat is not normal. It was normal when I started. Now it's not normal. That's an anesthesia problem. What is the problem coming from? More than likely, the cat was cold. Warm them up. In the meantime, give them atropine. So every time I talk about a problem, there is a checklist. And there are things that sometimes cause those problems. And then we do troubleshooting. Can we fix it? And that's what we're going to talk about. Now, obviously, mucous membrane color, or, you know, we're going to look, are they getting pale? What happens when they're getting pale? Are they losing blood? Are they cold? Did I give a drug that causes vasoconstriction? So I start thinking, what makes an animal pale? Unless you see an artery squirting out of the abdomen, or you got an abdomen full of blood, they're probably not losing blood. So what are the other reasons that cause pale mucous membranes? So we start troubleshooting that. Hypothermia can do that too. Dexdomitor causes pale mucous membranes. When you guys do radiology, hopefully when we get back next term, somebody is going to be the anesthetist for every radiology patient. You guys use a lot of dexdomitor. Now those dogs are sedated. They're not asleep. They are sedated, varying degrees of sedation, but the drug we give makes their mucous membranes very pale. And I've had students kind of freak out. They're like, oh my God, like he's so pale. And I was like, do you remember me telling you, you're using this drug, it causes vasoconstriction, makes them look pale. It's normal if they get that drug. If they don't get that drug, then I'm kind of going, okay, why are we pale? So we do this little checklist. Refill time is an indicator of perfusion. You'll hear me say perfusion probably more than you ever want to hear me say perfusion. That is the job of the heart and the blood pressure. The relationship between heart rate, blood pressure is basically making sure blood is getting to every cell in the body. And when perfusion gets to the organs, it gives oxygen and gets rid of CO2. So normal perfusion, we have to maintain perfusion. And anesthetic drugs alter cardiovascular function, and they alter blood pressure. So the goal of anesthesia is to not interfere to a degree that's going to cause harm. So we're going to talk about how to battle. So one thing I look at is refill time. And obviously we take a blood pressure, put a little cuff on them, and temperature. So we got to make sure, again, most of the time we're starting with patients that have a normal temperature, but anesthesia greatly affects that. Now, I'm looking at all of this to create a picture to make sure my patient is well. That is the goal of maintaining anesthesia, to keep everything in that normal range. Now, those were all vital signs. So those are like function of the physiology of the organs. Now we got to look at reflexes, because reflexes are a great way to tell me, is my patient light or deep? And I'm pretty psycho about this. I'm always checking them, because there can be subtle changes, but they are going to tell me how deep my animal is. And when you guys, if you've ever watched anesthesia at school, or maybe you're in a clinic, they have a vaporizer, okay? And sometimes people turn the dial back and forth, because isoflurane goes from 0 to 5%. Patients, 5% is the max you can run. I don't usually run maintenance or keeping them asleep at 5. I'm usually like 1.5, maybe to 3%. We talk about that when we do gas anesthesia. But I'm constantly looking at my vitals and my reflexes. Your goal is to always run the smallest amount of anesthetic possible to your patient, where you're still able to perform the surgery. So you're constantly using these reflexes to balance, can I turn them down? I'll give you an example. Palpebral is the first reflex listed right here, okay? That is where you tap and you see if they blink, okay? Obviously, if I do this to an awake animal, they're not gonna like it, they're gonna blink. If I do this to a dead animal, they're probably not gonna blink, okay? So as I travel from awake to deep, that reflex is probably gonna go away. So if I start tapping it and they're still blinking, but it's slow, I'm like, okay, they're going to sleep because it's being diminished. If I tap it and there's nothing there, then I have to look at their breathing and their other reflexes to say, are they too deep? And sometimes I turn them down. And when I turn them down, all of a sudden I start tapping and they start blinking again. And I'm like, well, okay, well, I don't want you to wake up yet. So I turn them back up. Do you see what I'm doing? I'm adjusting my anesthetic based on my reflexes. Because when you wake an animal up, you should start to see them blinking. And when we turn off the anesthetic, we expect these reflexes to come back. So now I will tell you, a reflex, involuntary, what did you say about turn them up and turn them down, the numbers you said? Okay, so I said on a vaporizer, and an anesthetic vaporizer, isoflurane, which we'll talk about later, but it goes up to 5%. So if I turn up the patient, like I turn it to 2, maybe 3%, and then all of a sudden my blink is gone, I might try to turn them down to like 2.5 or 2 or 1.5%. I turn them down, and then all of a sudden they start blinking again. Well, then I turn them back up, because I'm trying to, I know if an animal can blink, they're coming to a state of consciousness. And under anesthesia, they need to be unconscious, but I don't want to make them too unconscious. So that's why I use the awake and dead, is like, you know what they do when they're awake, you know what they do when they're dead. We're going to keep them somewhere in here, and you're going to use these reflexes to assess where they're at. And now, like swallowing and laryngeal, when we put an animal under anesthesia induced with propofol, they have to lose their swallow and laryngeal reflexes because that's how you can put a tube in the trachea. I've had animals where I'm trying to put the tube in and they keep swallowing and I can't get the tube in. So what I do is I give a little bit more propofol and then they give me less resistance and I put the tube in. Now, an animal that's asleep shouldn't be swallowing. They should lose that reflex. But I've had dogs on the table, all of a sudden I'm talking to the surgeon and I can see their neck and their throat. And all of a sudden I see a little swallow movement and I'm like, wait a minute, we're swallowing. So I've had to sometimes turn them up because obviously when an animal starts to wake up, they're going to feel this weird thing in their throat. And one of the things when we talk about extubating a patient or waking them up, you need to see them swallow at least 3 times. When I see them swallow 3 times, that means they probably have some significant swallow reflex because when I take out the tube, the larynx has to be able to close and they have to be able to swallow to protect their airway. So when you stop anesthesia, if you pull the tube and they have no reflexes yet, they could potentially aspirate. The job of the larynx is to close. So the laryngeal reflex is to close, and the swallowing shows me that all of that function is back. So the degrees of swallowing will tell me, am I awake? Am I not awake? Now, papillary light reflex, it should say pupillary, not papillary, sorry. Not. Speaking about swallow and coughing reflex, I didn't do that on purpose, but is their response to light. Now, I will tell you the 2 on here, corneal and pupillary light reflex. I don't do that on every patient. It's good for horses because horses their palpebral is not as accurate. So if you touch the cornea, now you're not using your finger because would you want to touch your eyeball with a finger? We take a moistened Q-tip and we will actually touch the surface of the cornea. And we're looking for blink and we're looking for movement of the eye. Pupillary light reflex, we would shine the eye. Now, an animal that's anesthetized should show a little bit of pupil constriction, but it is diminished because pupillary light reflex is brain function. If I'm anesthetized, they don't have adequate brain function. They're anesthetized. So that I expect their corneal reflex to be slow. But an animal that's dead has no pupillary light reflex. Do you see where I'm going? If my cat or my dog looks like saucer eyes because their pupils are completely dilated, I got to look at my other reflexes and say, is this patient getting too deep? And that's how because you have to use these all together. I never use, and if I haven't said this right off the bat, I never use just one of these. I'm not just looking at blinking. I'm not just looking at swallowing. If I'm concerned that I don't like a reflex, then I'm going to look at my vital signs and my other reflexes to try and create a picture. Yes, Miranda, everything slows down with anesthesia. I expect a lower heart rate. I expect a lower respiratory rate. I expect a diminished reflexes. It's the degree that these are diminished that is important to me. Yeah, and Katie, I'm glad you said that because jaw tone, which is not on here, is not technically a reflex. I sometimes put it under the umbrella of reflexes because I'm assessing it with reflexes, but it's an indicator of muscle tone. When you're anesthetized, you shouldn't have muscle tone. You're asleep. One of the best indicators that my patient's getting ready to swallow or wake up is I try to open their mouth and all of a sudden I start to get resistance because the more awake they get, they're going to start to feel you stretching their mouth and they're going to start to resist. If you remember when I talked about the case that I had at Purdue with the vet students, they anesthetized the dog and I was talking to them and I always just I take my fingers and I just move their jaw. It gives me just an indicator because when I first anesthetize them, I expect a little bit of jaw tone. it's going to start to go away the deeper. But when I first give them the drugs, they're going to have some tone. This dog was like flapping in the wind, and I was like, whoa. And as soon as I felt it, I started checking vitals. Heart rate was like in the 30s. Dog was barely breathing. Eyes were central. There was no blank. So you see what I'm saying? I didn't like the jaw tone. And then I looked at all my other parameters, and everything was telling me that this dog was extremely deep right off the bat, which is abnormal. And that's why we woke the dog up. We like flushed fluids. We started turning off the gas. We started bagging with oxygen. Had that dog stayed under anesthesia, he would have went into cardiac arrest. I don't doubt that at all. So just by picking up what is normal for this part of the procedure, that was highly apt. So it's not a reflex, but muscle tone is going to tell me. And kind of pedal is related to this. Now, pedal is a reflex, okay? This is where you pinch between their toes, or you pinch a toe. So a dog's laying here on the table. A lot of times I take my nail on my finger and I pinch. And I'm not talking about, I mean, I am pinching, okay? Because I'm not going to hurt them. I want to know if they can feel that. Because if they can do this when I pinch, they are not adequately asleep. And it is a reflex. It's the withdrawal reflex. It's called a pedal reflex for, the pause. But it is also an indicator of muscle tone, because if they can feel it, they also have enough muscle tone to pull their limb so you're testing nerve function when you do that. Are the nerves able to sense pinching, and then does the animal have enough muscle tone to pull? Okay, so I know I'm going into a lot. We're going to keep talking about these, but I want you to get an indication of what is a vital sign, what is a reflex. You're going to use them all together. And I just gave you the example of, the jaw tone was really crappy on that dog. The next thing I did was like, what's this dog's heart rate? What's the pulse? What's his color? Eye position, I'm going to get into, because that is huge. And he was central and looking at me. Now, I told you, they look at you when they're awake, and they look at you when you're dead. They start to move in all the other stages. At this stage, the eyes were looking at me, heart rate was low, respiration was low, no jaw tone. What is that all telling me? Do you see how it's painting a picture? Now, if this dog was looking at me and his heart rate was high and he was blinking and his respiratory rate was high, that's a dog that's waking up. Do you see, like, eyes looking at you are going to either be, I'm really awake, or I'm getting close to death, So then I have to use all my other parameters to tell me which way I'm going, okay? So I'm going to build on that. What I'm going to tell you is what these parameters are doing at these depths of anesthesia. That's what I'm trying to explain to you. Now, drugs alter a lot of these. I just told you dexdomitor causes pale mucous membranes. Is that a problem because of my patient? No, it's a problem because of the drug I gave my patient. There's a difference. We typically are going to monitor, and then also if the animal has a disease, if they're anemic, they're going to be pale. That's the reason they're pale, okay? And animals are all going to respond differently, but as long as we usually monitor every 5 minutes during anesthesia. I am sometimes checking these things more often. You are going to record all the vital signs, your anesthetic concentration every 5 minutes, or it's every 10 minutes at the school. But I don't take a parameter and then sit there and do nothing for 10 minutes. I mean, I'm just not built that way. But a lot of things can change in 10 minutes. So I'm constantly kind of feeling my patient. And that's the other thing, is that my hands tell me a lot. The monitor, I can do anesthesia without a monitor. If you have a stethoscope, you have hands, you have eyes, and you have a brain, you can do anesthesia without a monitor. Now, a monitor is nice, but it's not the end all be all. You have to be comfortable with this. So what I'm really talking about is there are stages and planes to anesthesia. Now, if you remember, and I'll have to get that picture from the last PowerPoint, there was the chart: alive, dead, sedation, hypnosis, narcosis, and then it went into the stages. When I talk about, we're going to talk about where we want to be. So there are 4 stages. There are 4 stages of anesthesia. When you get to stage 3 of anesthesia is split into 4 planes. So there's going to be stage 3, plane 1, stage 3, plane 2, stage 3, plane 3, and stage 3, plane 4. So within stage 3, there are variations that we're going to look at. Now, Miranda, this kind of relates to what you said right here. From stage 1 to stage 4, there is a progressive decrease in pain perception, motor coordination, consciousness, reflex responses, muscle tone, cardiopulmonary function. I know when a patient goes from awake to anesthetized, all of those things are going to be decreased or diminished. I don't want them conscious. I don't want them feeling pain. I don't want them to have muscle coordination because then they're able to move. You don't want them moving during surgery. So they, I don't want them feeling surgery. I don't want them moving. I don't want them conscious during surgery. Okay. But the things that decrease the cardiopulmonary function it's going to be diminished, but we have to balance where we don't diminish it enough to cause harm. So that's the balance. I need my patient unconscious, not moving, but I need to maintain enough cardiopulmonary function to not disrupt the body. That's the goal of balanced anesthesia. So if we go to the first stage, and I want you, I think on the homework, it was like, list the stage and then tell me a couple things that, how do I know I'm in stage 1? What does a patient in stage 1 do? So stage 1 is, now if I'm an awake patient, if the dog is awake, I'll keep saying dog and not me. If a dog is awake, they are in stage 1. If they are pre-medicated with a sedative, they are in stage 1. So when you get the dog out and we give them a sedative and we put them in a cage, they are in stage 1. So this is the stage, though, that they're starting to lose consciousness. They are not unconscious, but if a dog has a pre-med on board, they are not going to be as conscious as when they walked in the door. So what happens in stage 1? Sometimes they can get a little fearful. They could be disorientated. They might be more sedated. Sometimes they might urinate and defecate because some of the drugs we sedate them relaxes those sphincters, and some drugs stimulate defecation. A lot of dogs that get morphine or hydromorphone, most often they will defecate at some point before anesthesia. Sometimes you're holding them and you're anesthetizing them and all of a sudden you smell something and I'm like, can someone look back there? Like I'm holding the dog and I'm like, are we doing something? And sure enough, yes. So some point in stage 1, we might see these. Now, initially in stage 1, sometimes when we give sedatives, because there could be excitement, that heart rate and respiration can initially come up. But think about, I'm not really talking about a sedated patient. Right now, we're talking about going from awake to anesthetized or under general anesthesia, which is unconscious. So at the end of this stage, this would be like you starting to push the propofol in the syringe. They're sedated. They're going to start to lose their ability to stand and to become, they're going to become recumbent. Now, stage 2, and I want you to know stage 2 should only be about 30 seconds to a minute. This would be an extra note to write somewhere on a paper or somewhere on the side. Stage 2 is called the excitement stage or the excitement phase. And we want it to be brief. This breathing is going to start to become irregular. Sometimes it's very interesting. The more experience you get with propofol, and I talk about propofol a lot because it's commonly used. We start to push propofol, and all of a sudden the dog's kind of like resting on you, and all of a sudden he goes, they start like sniffing and looking and breathing, because what's happening? They're starting to lose consciousness. And so sometimes they do this, like I would say almost 99% of the time, the dog looks up at me and he starts sniffing and he starts looking around, because we're going through this excitement phase. Stage 1, Michaela, it's going to depend on the drugs you used. Now, if you sedate a dog and you give them 30 minutes to become sedated, that's 30 minutes. You see what I'm saying? So stage 1 is awake to sedated right as you start to give the propofol. Now, when you start to give the propofol, they're going to leave stage 1 and go into stage 2 pretty quickly. But a lot of it depends on the drug you're using. So does that make sense? The only stage I tell you really a time frame is this stage. This is the one, because I want you to realize this should be short. This is when they start to vocalize. They might start to struggle. I've had dogs paddling. In their head, I don't know what's going through their head. They're trying to run away from me, and they can only do this. Initially, because it's excitement, heart rate goes up, respiratory rate goes up. Sometimes they get really tight. They still have reflexes in stage 2. So they should still be swallowing. They should still have jaw tone. They should be blinking, but they're leaving consciousness. Now, there's a big thing, I should underline this and make this bold. Actions in this stage are not under conscious control. A dog that is in true stage 2, I've seen them, be very careful. I've had a dog throw his head up and crack me under the jaw, because I was kind of holding a dog and they were giving the drug, and someone asked me a question, wasn't really looking at the dog, I was kind of holding him, but he just thrashed, and I was like, you got me good. Oh man, like it's an uppercut. And I had to kind of, especially if they bite in this stage. So I'm very careful when I put my fingers near their mouth, because if they snap, get your finger in there, they don't necessarily know what they're doing. So you got to be really cautious in this stage, because they are not kind of under control, so to speak. Now, as you're pushing the propofol, my goal, when I talk about propofol, I talk about this, but let me mention it. When you push propofol, you're going to have a dose, and we usually push half the dose in like 30 to 60 seconds. You don't blast it in, and you don't go drip, 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 drip. If you give propofol too slow, you're going to spend more time in stage 2, and you're going to see more of these side effects. I've had dogs screaming, thrashing, and I'm like, push it, push it. Now, I don't mean push it, but I'm like, you got to push it faster. You got to get them through. Because in this stage, the only way to get them out of that is you got to get them asleep. So sometimes you got to speed it up. If you, in an ideal anesthesia, you go from stage 1 to stage 3 and you barely see this stage. That's a good anesthesia. You have a well sedated patient, you give your drug really nicely, and they just kind of go. But some patients are a little higher strung. I say they're a little wound for sound. Sometimes they were a difficult patient awake, and sometimes they go through this stage a little bit longer. So short stage, excitement, thrashing, push them through. We want to get from stage 1 to stage 3 as smooth as possible. Now, stage 3, this is where, I'm sorry, hang on a second. Okay. This is when we begin surgical anesthesia. Okay, can't do surgery in stage 1. You cannot do surgery in stage 2. You really cannot yet do surgery in stage 3, plane 1. So this is the very beginning of stage 3. Stage 3, plane 1, that respiratory rate that kind of sped up is going to start to come down, and we're going to start to get in a resting respiratory rate. We shouldn't be moving really at this stage. So now we should start to become unconscious in stage 3 plane 1. That's the first time they really start to become unconscious. Here is the big thing I want you to know right here. It says eyes start to rotate ventrally. When an animal goes under anesthesia, I said they're awake, they're looking at you. When they start to go to stage 3 plane 1, they're going to start to roll. So if I look at my dog's eyes, if I go like this, I expect them to start to rotate ventral. Eventually, they're going to rotate medial. They should be, when they're at a good spot, their eyes are looking at their nose. If you go like this, they're ventral and medial. That's where I want my eyes. And I'm telling you what, the reason I keep saying that, it's one of my better indicators of my patient's status is my eyeball position. And I tend to look at it a lot because they're going to move different ways during anesthesia. That tells me where they're at. So eyes rotate, they start to become, the pupils are going to be a little more constricted. So at this point, we're going to have a little bit of pupil constriction. I'm going to tell you, we're not really checking pupillary light reflex right now. This is right now a lot's going on. You're giving the drug. This is when you are going to intubate. If I ask you when you intubate a patient, it is in stage 3 plane 1. In stage 2, they still have a swallow reflex. They still have some jaw tone. You're not going to be able to open the mouth and pass a tube. Okay, they're going to be anesthetized. And this is when you hook them up. Now, stage 3 plane 1, they're going to have a blink, but it should be diminished. They're going to have some jaw tone. It's going to be diminished. I don't necessarily want them to have a swallow reflex because I have to put their tube in. If they're swallowing, I can't put my tube in. So you start to lose swallow and laryngeal first, then you're going to start to lose blink and jaw tone. Okay, so this is very not adequate for surgery. This is where you want to live for surgery. Stage 3 plane 2 is surgical anesthesia. Our heart rate and respiratory rate are decreased, but they're regular. So I should have kind of a slower respiratory rate, slower heart rate. Respiration isn't going to be as deep. They're unconscious. So I don't expect them to have the muscle tone to take a deep breath. So they're going to breathe more shallow, more slow. Heart rate's going to slow down. The muscles are going to be relaxed. If I pinch the toe, there should be no pedal reflex and there should be no swallowing. Now, swallowing, you don't check that. Well, what you could do is you could open their mouth and pull their tongue. If they have swallow reflex and you pull their tongue, they should pull it back. Okay. So an indicator, a lot of times I have their tongue pulled out of their mouth because I have to put the little pulse oximeter. So a lot of times their tongue is outside of their mouth, but what I'll do is I'll check their jaw tone. It should be loose. They shouldn't pull their tongue. They shouldn't be blinking. They shouldn't be smiling or should have no jaw tone, no blink, heart rate, respiration are slower. This is where you do surgery. Their eyes are rotated ventral and medial. So when I look at the eye, I want to see it looking at the nose, ventral and medial. That's where your eyes want to be, okay? I'm probably not going to do a corneal reflex. I'm probably not going to do a pupillary light reflex unless I had a patient I was really concerned about brain function. If I'm really worried, if I have a brain tumor patient and I radiated patients with brain tumors, I would look at their pupillary light reflex. I'd look at the corneal reflex. But most of the time, your palpebral and your other reflexes are good enough for your every patient. Now, stage 3 plane 2, the other thing to realize, you're doing surgery right now. Dr. Ritz is starting the spay. It is somewhat normal when she starts to cut, or especially during a castration when she pulls out the testicles and she clamps the cord. I have a lot of dogs where the heart rate will increase and they'll kind of, they'll huff and puff. A lot of times once she removes the clamp, they go back to normal. So I mean, you have to keep an eye on them. They could be getting light and waking up, but there are some portions of some surgical procedures where I'll see the patient react a little bit and then they go back to sleep. So you could see when you start surgery, you have to, most of the time your surgeon's going to tell you they're starting. Or if my doctor, like when we did stifle surgery, anytime they opened the joint capsule, my dogs would huff and puff. So he would always tell me, he goes, I'm going into the joint capsule. And I'd be like, okay. So I'm ready to give the dog some breaths or potentially give them more drugs if they react too much. But a lot of times once he popped through the capsule and kind of got in there, they go back to normal. So I'm just telling you, the more experience you get, realize that even though you're like, yep, Dr. Ritz, you can start, my dog is asleep, there's going to be sometimes parts of the procedure where we get a little bit of stimulation. But your patients should still remain unconscious and immobile. They're not going to be able to lift their head. They shouldn't be able to pull their legs. Stage 3, plane 2, they should be completely unconscious, completely immobile. If you do look at the pupils, they're going to be sluggish, okay? Pupillary light reflex is one of the last reflexes to go away. So what happens is, even though they're not blinking, they're not moving, they're asleep, I do expect the pupil to somewhat kind of do this, okay? It's not going to be like that, okay? But I want to see a little bit. But again, you guys probably won't be doing that in there unless you really were concerned about a patient. Now, stage 3, plane 3 is considered deep anesthesia. A patient in this stage is still okay. They're going to live. They're probably just a little deeper than they need to be. Remember, I said you're always going to be turning your dial and trying to turn them down. So this is like, you know, we've left them turned on. Maybe we turned them up when they were painful and we never turned them back down. So now what's happening is our heart rate and respiration, where they were kind of hanging out, now they're starting to go down a little bit more. Heart rate's going down, respiration, feeling a pulse. Now, I will tell you, during a surgery, the dog is on drapes. You could go to the back of the animal, kind of reach under the drape and feel the femoral pulse. But the great place to feel a pulse on an anesthetized dog is the lingual artery. They have an artery that runs under their tongue. Now, I have a dog laying on the table, sticking their tongue out. I just put my fingers on there on the tongue. They have an artery that runs on each side, the lingual artery. So I can put my fingers on the tongue and I can feel their pulse. So if you've been monitoring that, that pulse strength is going to go down because blood pressure is dropping. Refill time is extended. Why? Because my blood pressure is dropping. If I don't have good blood pressure, I'm not going to have a good CRT because I don't have adequate perfusion. The light reflex is going to be diminished. The big thing here, central eyeballs. Remember when I said they're stage 3, plane 2, they're looking at their nose. As they go deep, those eyes are going to start to rotate back central. Okay, so if your eyes are starting to come up again, then they're probably starting to get a little deep. Reflexes, most of my reflexes are completely absent, which most anesthetized patients, they are going to be absent. But one thing to add on here that is not written, well, it says muscle tone is very relaxed. So this is your jaw tone is like, so sometimes I'll feel a dog and I'm like, it's relaxed. And then I'm like, it feels even more relaxed. Okay. So now they're getting deep. For example, if you don't like your heart rate and your eye position is central, what I've told students is when I have a dog looking at me, eyes are central. They're either too deep or they're waking up. This is very important because how do I know if my eye position is bad, is meaning something bad? If their eyes are rotated up and their heart rate is going up, their respiration is going up, they are starting to blink and they have muscle tone, it means that the eyes are going up because they're getting too light. If my eyes are going up and then my heart rate is going down and my respiration is going down and there's no blink and the jaw tone is really loose, your patient is too deep. Does everybody understand that? Because these are the gut feelings, and this is what your job is. Your doctor is going to be doing surgery. You're doing anesthesia. You are going to have to start to make assessments. You obviously can always ask your doctor, but part of being a good technician anesthetist is like, what is my patient showing me? What does it mean? Okay. When a patient is looking at you, it means one of two things, and I've just explained. How do I know what it's telling me? Too light or too deep? You got to look at your other values. You have to look at your other parameters, and that's going to point you in the right direction. So if I'm getting too deep, eyes up, things are going down, reflexes are diminishing, heart rate, respiratory diminishing. Now stage 3, plane 4 is we're getting into like an overdose situation. And this means you're running. Now I'm talking about the everyday patient that gets a pre-med, that gets propofol for induction, and that is put on gas. If you've turned up the gas and you've left it, and maybe you forgot, or you're watching the surgery, or you get busy, what happens is you're starting to see this abdominal effort. Sometimes they're using more abdomen to breathe. Why? Because the brain is taking over the diaphragm. When an animal goes agonal at the time of death, remember I said the brain kind of tries to trigger the diaphragm, and they do this. And it's very jarring to see. It's not a good thing to see. It's the brain's last-ditch effort to take over. So remember, the body is trying to keep everything in hemostasis. If we are getting too deep, the brain is like, well, I got to do something. I'm going to start recruiting the abdomen and the diaphragm to help get the animal to breathe. We've got very dilated pupils. They look like saucers. No reflexes present, and I have cardiovascular depression, low heart rates, really low blood pressure, very increased CRT, because if my heart is not pumping and I don't have adequate blood pressure, you push on the gums, it's going to take longer. So CRT, I'm constantly under the table pushing on the gums. I'm always doing it because you're going to pick up on subtle changes if you monitor it on a regular basis. And then the final thing is like, they're just very flaccid. Like I said, sometimes what I noticed in that dog that was going to die was as soon as he was induced and I went to feel the jaw, it was like, whoa. I mean, it was just like, and I was like, whoa, 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 whoa. This is way too flaccid, way too loose, right at the start of a procedure. That is abnormal. If you're feeling jaw tone the whole procedure, you're going to pick up on subtle changes in muscle tone. Okay, it's going to get very loose. If we get into stage 4, then this is anesthetic overdose, way too deep. Typically, respiration is going to stop. And then we have to put in resuscitative methods. Now, I will tell you, if you're ever unsure of where your patient is, or you don't like something that is going on, I've never had a doctor mad at me if I've turned things off, I've turned the patient way down, and then if you're wrong, everybody says, better late than dead. Better late than dead. If you're ever concerned, because I'm going to tell you as a new tech, and I've been there before, you're unsure. Nobody wants to look stupid. And sometimes people are like, should I say something? I'm wrong. Oh, I don't know. That's right. What did Miss Landers tell? Oh, I don't. You're sitting here. Say something. It's not going to hurt to. I've never faulted anybody for turning a patient down or asking me a question. And nobody should make you feel stupid for asking that. And if they do, you tell me about it. And we will have words. Because I don't want anybody to feel intimidated to ask a question, especially when you have an animal under anesthesia and you are concerned. And I take that seriously. So I had a patient that did this in radiation, and I didn't like his ECG and stuff. And my boss thought I was doing radiation, and I turned him off, and I kind of turned up some fluids, and I was like, I don't like it, this and there. And she's like, she comes in, she goes, I think he's fine, and this and that. And then he started waking up, and then she goes, let's do radiation. So I had to basically turn everything up and get him re-anesthetized. My boss was not mad at me. Did I make the right call? I mean, he ended up being fine, but something made me feel weird. And I turned, yes, better light than dead. Better light than dead. So in that case, did I delay the procedure? Yes. Did it take longer because I basically had the dog asleep? I woke him up, kind of. He wasn't fully awake, but then I had to get him back asleep so I could do radiation. But in my gut, something felt weird. I made a call. The dog kind of woke up. I had to make him go to sleep again. No harm, no foul. But like I said, most doctors I've worked with, they will pause. And I've had to tell people, I've had to tell doctors, you got to stop. Because they sometimes are doing surgery and I don't like something. And I was like, stop a minute. And and I'm like, hang on a minute. I'm concerned. And then they finally go, what are you concerned about? I'm like, I don't like his rate. I don't like his ECG. I don't like what he's doing. I get my doctor involved. I'm trying to troubleshoot it. So sorry, I get worked up about this. I always want you to make sure you feel comfortable saying something. And I want you to make sure that if you feel like you need to turn the patient down, I have turned patients off, completely turned the vaporizer off. Because when you turn it off, they come out of gas anesthesia very quickly. So the fastest way for me to kind of get a patient, and then if my reflexes start coming back and my patient's okay, you can always turn them back up. So that's why I say better late than dead. Make that call if you have to. I know you guys have to go. So let me stop here because I kind of want to get into this with surgical anesthesia. Do you have any questions? Oh, thank you, Joycelyn. The reason I say this is I've had students in the past tell me, well, I maybe got snapped at, or someone said this or someone said that. When it comes to you asking questions about this, I don't ever want you to feel uncomfortable. And so I don't have an issue going to bat for you. I don't have an issue talking to someone and saying, this is what happened. I'll get all the information. But, you know, there's no sense in a surgical procedure if the patient dies. There's no sense taking an x-ray if the patient's going to die. So if we're concerned, the ultimate goal is an alive patient, so we can always put a procedure on the back burner and do the procedure. Yeah, and I know as a student, there's times where I get excited about something and I answered something, and then I was totally off base, and then I sink back into my chair and I'm like, I'm never answering another question again. Oh my God, I feel so stupid. I mean, I've been there. I shouted out an answer to something at a conference and I was off base and I just wanted to leave the room. I was like, okay, that's not what I wasn't thinking the right thing. So it's, you know, not expecting everything to be memorized, but as a student, your ability to ask questions and sometimes your gut. Again, you will develop more of a gut, but there are going to be instincts, feelings. When I opened that dog's mouth and it was way open, turn him off. My patient's dying, turn him off, get the doctor. Sorry, I paused. I just shut everything off. If I was wrong, what did I lose? We just got to make the dog go to sleep again. But I wasn't wrong. I've been wrong and I've not been wrong. But in both cases, it was the better thing to do. And my doctor appreciated that. So that's all I'm going to say. Stage 3, plane 2, Kayla. Stage 3, plane 2. So stage 2 is just, stage 1 is by itself, stage 2 by itself. Stage 3, plane 1, plane 2, plane 3, plane 4. And then stage 4 is by itself. So stage 3, okay, that's what I figured. Yes, that's where you want to live. Stage 3, plane 2 is surgical anesthesia. And you're going to maintain how you know to keep a patient at stage 3, plane 2 is going to be based on your heart rate, your reflexes, all of your data. And you know, like I said, if you turn a patient up and the eyeballs start coming up and heart rate starts going down, that's telling you you're going into stage 3, plane 3. And you're like, wait a minute, that's getting too deep. Let me turn it down. And the eyes rotate back to, you know, so that's what I'm saying. You're going to always be moving that dial and making adjustments based on these reflexes, eye position. Eye position's probably kind of addicted to it. That sounds weird. No, I mean, I'm constantly looking at their eyes. I don't go like 10, 15 minutes without looking at their eyes. I'm kind of like, I'm not an OCD person, hardly at all. But when it comes to that, I'm pretty OCD. I'm always looking at that, always feeling their jaw. It's just, because I got to do it. I got to do it. Okay. All right, well, it's 11. I want to let you, I got to get ready to go. I'm going to sleep in the car, hopefully. If you have questions, you have the homework. Does anyone want to ask anything? Yeah, I know, puppy time. I don't know, I'm all excited, but then I'm like nervous at the same time. I haven't had 2 dogs since high school. And the second dog I got was an adult dog that was abandoned. It was in high school. I did kennels and they abandoned an adult golden retriever. They gave us a false address and a false phone number, and he was abandoned, and they were eventually going to put him to sleep. And I was in my high school, they didn't have rescues. So we tried to adopt them out, and then my boss was like, we got to put this dog to sleep. So we had to make room for boarding. I was like, nope, I'm taking him home. So I had 2 dogs, but the second one was an adult. So yeah, I haven't had 2 dogs in a long time. So yes, I wish I could bring you all along. This is funny. Don't worry. It's going to be probably photo overload. Maybe I'll try to post some pictures to your page, or you'll get to see them live tomorrow. So, all right. Well, you guys have a great rest of your day. I'll get this converted and emailed out to you, and we'll talk tomorrow. Have a good one, guys. All right. Bye-bye. Bye. Thank you. Oh, dear. Okay.